explain to you a little bit about what cardio-oncology is. What is it that we do, and what is it that is so important? This is actually a brand new specialty. It didn't exist 10 years ago. As a matter of fact, my own path in cardio-oncology started approximately at that time when our chief of breast oncology asked me to help her in evaluating heart function in patients who were receiving a medication called trastuzumab, which some of you may be familiar with. It's called Herceptin. It's a medication that we use in breast cancer for patients who express this particular receptor called HER2. And these patients that receive these medications do much better. They have much less of a chance of recurrence when they take this medication. But the medication can also cause problems with heart function. And at the beginning, we were not so sure as to how many patients were going to have problems with this. So I started to help her, and then I discovered that I really like this. As a matter of fact, many years ago, when I decided to become a cardiologist, I was between oncology and cardiology as my the specialties that I wanted to go into. And now having the opportunity to do some oncology was great for me as well, because it brought me back to one of my passions. The other reason why I became a cardio-oncologist is because through the years I saw patients which came to me as second or third opinions because of heart disease that nobody could diagnose properly. I ended up being that they have something called radiation-induced heart disease. Years ago, many patients, when they have particularly a malignancy called Hodgkin's lymphoma, is a disease, a cancer of the blood, so to speak. These patients used to get something called mantle radiation, which means that they had radiation in the entire chest. And the radiation, we didn't know at that time, took care of the cancer, took care of the lymphoma. These patients survived, but the radiation ends up being that through the years, sometimes 10, 20, 30 years later, ends up damaging the heart. And we did not know that. But I started seeing patients that came to my practice with this. And at the beginning, I can tell you that I wasn't sure that I diagnosed properly the first patient. This is probably 25 years ago. But since then, I've seen many patients that I recognize as having this condition. Um, so this motivated me to go into this. And right now, I run the service at our institution. It's a very busy service. We have a branch of the Moffitt Clinic from Tampa here. They specialize in malignancies of the blood. We do bone marrow transplants. We do all kinds of procedures that end up resulting sometimes in cardiovascular complications, complications that involve the heart and the vessels. So I'm involved with them a lot, and heavily involved with our breast oncology clinic as well as other services in our oncology department. We have a very large Memorial Cancer Institute that essentially provides services in all modalities of cancer therapies. Um, why is this important? Why is it important to have a cardio-oncologist? Um, my first slide is going to look incredibly complex to you. And I'm not going to show you what that slide is in detail. It's just going to show you why this specialty is so complex. Going back a little bit, so cardio-oncology essentially is a new specialty. We now have our own dedicated journal in which we publish research which we didn't have before in the treatment of the cardiac consequences of different therapies. So cardio-oncology essentially is a specialty that treats patients that are affected by the different therapeutic modalities, the different therapies that we use, the different treatments that we use to treat cancer, whether it is conventional chemotherapy, whether it is something new called immune checkpoint inhibitors, which is a form of immunotherapy, whether it is radiation therapy. Every therapy that we use has the potential to affect the heart or the vessels, sometimes causing significant hypertension. So we take care of all these things. In addition to that, we know that if you survive your cancer, the chances are that you will not die of a second malignancy. It is possible. The chances are you will die of heart disease. So we don't want that to happen, of course. So one of the things that we do here is we have a survivorship clinic in which we see patients who have been affected by chemotherapy, and we follow them through time, making sure that we control the risk factors to have heart disease. The other aspect that is important in this is that even if you have cancer, cancer is not everything. Many patients have other conditions, so we cannot ignore those conditions just because you have cancer. If you have significant high blood pressure, if you have diabetes, you have established heart disease, like having blockages in the arteries of the heart, for example, we need to treat that as well. We can uh, chew gum and walk at the same time, so to speak. So we should be able to treat your heart, your blood pressure, your cholesterol, and take care of the cancer as well. So this is my first slide. And as I told you, it looks incredibly busy. Don't be concerned. We're not going to go over this. It's just to show you the complexity of this condition. So if you can see here, this is just a slide that shows the studies that we have for a particular type of medication. This is called a PD-1 pathway combo. This really doesn't matter to you. It doesn't need to. It's just a combination of two medications that we use to treat cancer. And these are the medical conditions that we can treat, from colorectal cancer to pancreatic cancer, hepatic cancer, hematologic, that means blood cancers, kidney cancer, bladder, etc., etc. This medication we can treat all of these things. And yet, look at the number of studies. These are the studies with this group associated. Each little point of this is with a different medication, another chemotherapeutic agent, another chemotherapy. From phase one to phase two, phase three, hundreds of studies, hundreds of possible combinations of medications. It is impossible to tell you what kind of cardiac complications you're going to have when you have this complexity of medical treatment. We just we just don't know. And these medications are being brought to market literally every week, because they save lives, is the right thing to do. But that we know everything that can potentially happen with these medications, we really don't. And that's why we need to keep patients like you under surveillance, because we need to make sure that your blood pressure is not affected, that this doesn't result in an increased risk of heart attack, for example, etc., etc. Um, so cardio-oncology actually is a specialty that grew up in the last few years, because before a few years ago, cardiac cancer therapies were very simple. There were very few medications that treated cancer effectively. We knew what they were, we knew what the cardiac consequences could be. For example, and by the way, many of these slides are medical slides, but I will translate to you, so don't worry about reading them. I'll guide you through them. So, um, before 2005, we have this medication called anthracyclines and a medication called 5-FU as the main medications. So anthracyclines is the red devil. Maybe some of you have received this medication before. It's called doxorubicin, and it can cause significant cardiac disease. As a matter of fact, I have a patient in the hospital right now who has been affected by this medication acutely, and we're treating her very aggressively to make sure that she survives not only the cardiac injury, but eventually her cancer as well. And the other one was 5-FU, 5-fluorouracil, which is a medication we use to treat mostly colon cancer. Now, um, after 2005, the number of medications that came into the market was enormous. And we needed to find out, like I told you before, from this breast oncology doctor that asked me to help her decide which patient could continue taking this medication. We needed to decide how to treat these patients. Who do we allow to continue therapy if it is affecting the heart a little bit? um, because many of these medications are life saving. And just because heart function, for example, was affected a little, it doesn't mean we're going to stop the medication. There's no point in avoiding heart injury if you're dead. So essentially, that's what it is. We want you to survive the cancer. So finding out that middle ground, that special point in which we don't do any more harm to the heart, and yet we allow continuation of the therapy for the cancer, is the key. And establishing cardio-oncology as a subspecialty allow us to do that. For example, you don't know this, but in most uh, uh, trials of cardiac medications or cardiac therapies in the past, patients with cancer were excluded. They were not investigated. If you had a group of 100 patients that were included in a trial and 10 had cancer, we said, forget it, you're going to be included in this trial. So for the first time now, we have trials in which we include patients with cancer, and we try to find out what happened with their heart with those therapies. We also were able to determine in the last few years that it is okay to treat cardiovascular disease aggressively during cancer treatment, and that we were not doing the patients any harm. We were very concerned. We were thinking, oh, what if I give you this medication? You're having problems with your liver to begin with because of the cancer. The medication can cause problems with the liver. We were able to tell and to show that it was okay to protect your heart and still treat the cancer. More importantly, we were able to show that we did not interfere with the therapy itself, that we continue treatment to completion. And later on in this talk, we're going to talk about a concept called permissive cardiotoxicity. And it sounds bad, but I'll explain to you what that means. Now, what is the problem with trying to predict what's going to happen with somebody when they receive chemotherapy? It has to do with this slide. And again, don't be too concerned. I'll guide you to it. When somebody's going to get heart toxicity because of these therapies, we have to take into account these things. There are patient-specific factors. It could be your age. It can be the fact whether you have high blood pressure, you have diabetes, what your heart function is. But also, we have to see what your genetics is. How do you tolerate these medications that give you for the cancer? Some patients can receive the same medication. As a matter of fact, most patients receive these medications without any evidence of heart disease. And yet, there's a small group of patients, and those are the ones that I treat, that we give them the same exact dose, the same exact age, same exact hypertension, and yet they will have heart disease. So genetics have to do a lot to do with that. And also, the other one is treatment-related risk factors, which is the medication that we're going to use. Not every medication for chemotherapy can harm you. Some of them, the heart really is not involved, but we know other ones that really can cause significant heart disease. Now, what kind of cardiac toxicities we're talking about? We're talking about things like failure of the heart to pump well. This is something called congestive heart failure. We can have problems with blockages in the arteries of the heart. Some of these medications can affect the arteries, cause inflammation of the vessels that go to the heart. And they are the same vessels that, when it's affected by cholesterol plaque, for example, put you at risk for heart attack. Well, some of the medications will do the same thing. These medications very commonly can cause problems with the rhythm of the heart, particularly a condition called atrial fibrillation. We see that tons. You guys may have heard the word atrial fibrillation when you're watching TV and they mention medications such as Eliquis or Pradaxa or Xarelto. These are the same type of arrhythmias that we have to take care of. Some of these medications can cause something called pericarditis. The pericardium is a membrane that surrounds the heart. The heart cannot be floating in your chest. It has to be contained, and it's contained by this membrane. And sometimes we can have inflammation of that valve. And then we can have deterioration of we have 4 valves in our heart. Any of them can be affected by the chemotherapy or radiation, for example. The other thing that we can have is that there are some tumors that metastasize to the heart, particularly the tumors that are in the chest. So breast, lungs, esophagus, the food pipe, they can all metastasize to the heart. It's very rare that we see primary cancer of the heart. Is of 100 tumors in the heart, 99% are metastases. Only 1% is primary tumors of the heart. Also, some of these tumors can cause problems with that sac that I told you around that surrounds the heart. They can produce an accumulation of fluid around the heart that we have to drain, for example. Now, what we try to do in a cardio-oncology clinic is to have a one-stop clinic in which we work in conjunction with an oncologist, and we have all the imaging techniques that we need to have in order to diagnose the different conditions. Those imaging techniques or technologies include ultrasound of the heart. These are called echocardiograms. They include magnetic resonance of MRIs, PET scanning, and CAT scanning, which you are all familiar with. Um, Regardless of everything that I've said, I have to point out that this is a very young specialty. It just started not too long ago. So we are very cognizant that we have very few trials about what works and doesn't work. We need better risk scores, which means a way of trying to prognosticate who's going to be hurt by these medications. That we have to find a way of telling the oncologist, you know what, maybe we should have an alternative treatment because the chances this patient's heart is going to be harmed is super high. So we need those. We need better way of diagnosing if the heart is being affected. We need better treatment algorithms, meaning that we kind of apply what we do in the general population, the population without cancer. For example, if they have heart failure, we use the same medication so the patient with cancer, but are we doing the right thing? We're not really sure. It looks like we are, but as I said, it's a very young specialty and we need to have better ways of defining what works and doesn't work. In the end, our job is to improve the quality of life of our patients and their actual survival. Now, which medications can cause problems? You would have heard about some of these medications. I'll go quickly of them. I mentioned anthracyclines, doxorubicin. This is the red devil that we mentioned before. The HER2 are the medications that we use for breast cancer, such as Herceptin. It's called also trastuzumab. Perjeta is another combination that these type of medications target this particular receptor. The most common medications that came out in the last few years are called tyrosine kinase inhibitors or TKIs. They generally tend to cause things like hypertension a lot. We have tons of them. The new kids on the block are called immune checkpoint inhibitors. These are medications that modify our own immune system to allow our immune system to attack the cancer and destroy it. Tumors have a way of making themselves like hiding to our immune system. When we do these medications, we take the blindfold off the immune system and we tell, hey, go after those cancer cells. And these medications then go after the cancer cells and kill them. Proteasome inhibitors are medication we use for a specific malignancy called multiple myeloma for the most part. And then they have this thing called alkylating agents that we use for a multitude of cancers. Um, Now, as I mentioned before, not everybody that receives chemotherapy or radiation therapy is going to have heart disease. As a matter of fact, I want to reassure you that most of you will never have any type of heart disease, but some patients will. And the patients who are most at risk are patients who have risk factors to have heart disease to begin with. So the most common risk factors are, for example, high blood pressure, particularly if not controlled, diabetes, particularly if not controlled, having very high cholesterol, having a family history of having premature coronary artery disease, meaning heart attacks at a young age in your family, in a first degree relative, or smoking cigarettes. So if you have any of those risk factors, or you had a heart attack in the past, or your heart has been affected for whatever reason in the past, then you're going to be more at risk. Now, uh, as I mentioned before, this condition called heart failure can occur mostly with the red devil, that is the doxorubicin or anthracyclines. It can happen with that medication for breast cancer called Herceptin, and it can happen with the medication for the multiple myeloma. But it can happen also because when we do therapies for cancer, one of the things we do with the chemotherapy is we give ton of fluids for patients to tolerate the chemotherapy well. If your heart, for example, if you're an older person and your heart is a little bit stiff as you get older, we all have that as we get older. Hearts get a little bit stiffer. They still pump really well, but they don't relax well. If I give you a lot of fluids and your heart isn't relaxing well, you may go in heart failure just because of the amount of fluids that we give you. So we have to be cognizant that can be a reason for that. Finally, there is a strong connection between the brain and the heart. Believe it or not, some patients will have something called a stress cardiomyopathy, which means that your heart function goes down just because of emotional stress or physical stress, for example, an infection in your body that affects your entire body, something called sepsis can affect the heart as well. Sometimes we have a stroke, it can do it as well. So it's not only the therapies for the cancer that can cause the heart to go bad, it's just the stress, the emotional stress of having cancer can sometimes make the heart go bad. And we're equipped to recognize that if that happens. Um, Now, going a little more specifically, and I don't want to get too much into the weeds on this, I just want to explain how this works. So, this medication called Herceptin that I talked to you about that we use to treat patients with breast cancer, um, when you are diagnosed with breast cancer, we want to know whether you have something called estrogen receptors or progesterone receptors or HER2 receptors. These are all hormonal pathways. If you have any of these, it means that estrogens in your body or progesterone in your body or this other pathway that I just mentioned are overexpressed, meaning we have a lot of that stuff in our body and they are kind of the fuel for the cancer. They make the cancer grow. So it is in our best interest to treat these different pathways. For estrogen and progesterone, we use hormonal therapies, but for HER2, we use this medication called Herceptin. The problem with this is that the same receptors that we're targeting when we're treating the cancer, and we target these receptors because if we target the receptors and we knock them out, then the fuel that the cancer uses to grow then goes away as well. And we stop the cancer from growing, we prevent the cancer from recurring in a lot of patients. The problem is the same receptor that we're targeting is present in the heart. So if we're targeting the receptor elsewhere, we're targeting the heart can go bad because we're targeting heart cells now. Now, does this happen a lot? Not really. We discovered at the beginning we're really scared because, and I'll point you, forget about these three lines. When we go to the last line, the toxicity was 27%. One out of four patients got heart disease when we used it simultaneously with the doxorubicin, the Red Devil. So we learned not to do that. Now we do it sequentially. When we do it sequentially, it's only 4% of patients that have a little bit of decrease in heart function, and only 1% of the patients develop symptoms of heart failure, which is mostly shortness of breath. So the risk, I believe, is a little bit overstated. I would say 99% of the patients will not have heart failure, so we don't worry too much about this. Now, if the heart function does decrease, we have two strategies. One is, I'm just giving you examples so you learn what is that we learned in the last few years. So the strategy here, what we learn is that if the heart function decreases by a certain amount, and that's what the second line says, then we give the patient a holiday. We stop for 4 weeks, we remeasure, and the heart function increases again. We give the medication again, and mostly the patients do well. However, we don't want to do that. We don't want to do that because we know that any stoppage, however small in the treatment, increases the chance of recurrence of the cancer later on. We learned that as we're treating these patients. So we conducted a couple of studies, and their name over here, in which we said we're going to accept that your heart function is going to suffer a little, but we're still going to give you the medication. We'll give you heart medications, but we'll continue the cancer medication as well. And guess what? This is a treatment that takes about a year. We were able to take those patients to the entire year, treat the cancer. The heart function did not get worse. After we stopped the treatment, the heart function became normal again. And by doing that, we allow the patient an opportunity not to have cancer again. And this is the concept of permissive cardiotoxicity. It sounds really weird, but in some patients, we say, we're going to accept that your heart is going to suffer a little with the idea that we're going to treat your cancer, because if we don't treat your cancer, you're going to die of the cancer. We want you to survive. We'll take care of the heart. Even if it suffers a little, we'll give you medications, we'll watch you. And as long as the heart doesn't get worse, we'll continue with the cancer treatment. Now, the other medication that I told you about are these things called TKIs. It's a very long name. You don't need to remember that. But these medications target vessels that supply the cancer with blood, for example. The cancer cannot grow if it doesn't have blood, it cannot survive. So we target those blood vessels. Unfortunately, when we target those blood vessels, we target our own healthy blood vessels that go elsewhere as well. So one of the problems with these TKIs, and this is a type of TKI they call VEGF inhibitors, is that they can increase the rate of hypertension. As a matter of fact, I would say that almost everybody that receives the medications, the blood pressure increases a little, sometimes not still normal, but increases a little. And in some patients, we get high blood pressure. So we treat them like we treat somebody with high blood pressure as well. In some patients, however, the response is so strong that the heart cannot deal with the stress and they can go into heart failure as well. So we treat that as we go. It's another example of things that can go back with chemotherapy. Now, I mentioned a few minutes ago this thing called immune checkpoint inhibitors. Immune checkpoint inhibitors work by something called releasing the inhibition of your immune cells to the cancer cells. So cancer cells are super smart. What they do is they target these receptors in our immune cells and they tell them, oh, there's nothing going on here. It's like an accident. The policeman saying, move on, there's nothing to see here. That's what the cancer cells tell our own immune system. Immune system believes it because the cancer cells were able to induce this receptor, and then the cancer grows. Well, we find a way of unmasking this mask that the cancer cells put in our immune system. It's called immune checkpoint inhibitors. By doing this, we allow these tumors to be treated by our own immune system, and the cancer tends to go away. This is the same medication that President Carter, who just died, received for his melanoma when he was, I think, 92, 93, and he was able to survive, what, 7, 8 more years? So they're incredibly effective. We treat them, we use them now in all kinds of cancer. The problem is that when we release the immune system, we release the immune system not only against the cancer, but sometimes against our own bodies. And we can get inflammation everywhere. We can get inflammation in our brain, in our hearts, in our lungs, in our gastrointestinal system. These patients can have bad rashes. They can have problems with nausea, diarrhea, all kinds of problems. We treat most of them, but the one that we're really concerned is that it can affect the heart and cause something called myocarditis. It's an acute inflammation of the heart, which has a tremendous amount of danger because it used to be about 50% of those patients died. Now it's much less, probably 30%, but it's still 3 out of 10 is a lot. Fortunately, it doesn't happen very often. It happens, I would say, very rarely, but we are very cognizant that it can happen, and we look these patients very closely to make sure that it doesn't happen. Again, I don't want you to be overly concerned. The number of patients we see with this is really rare, but it's one of the things that we treat. That's what we do in cardio oncology. Um, we're going to go in this. Now, I'm going to switch gears a little bit because we talk about cardiac toxicity, but one of the things that these medications can do as well is that patients with cancer tend to clot a lot. They have something called a prothrombotic environment, so to speak. We have a dictum that I always like to quote to my students and my residents and my fellows, and I tell them, listen, 20% of all clotting that happens in our body that is bad, for example, in the veins of our legs, something called deep venous thrombosis, we shorten it by saying DVT. 20% are patients with cancer, and 20% of all cancer patients will have at some point a clotting problem. So it's something that we are super, super careful to recognize. We have an increased incidence of this when you have lung cancer, pancreatic cancer, colon, kidney, prostate, and we have metastases. So when that happens, we look for this. I have a patient actually in the hospital right now that we thought that she was having a little bit of heart failure. And today we check her lungs, and it happens to be that her lungs are full of clots in the vessels of the lungs, something called pulmonary embolism. And it happened to her because she has breast cancer, something called triple negative breast cancer. And even though she came from an infection and she was getting ready to go home, she started getting short of breath. We thought it was a little bit of extra fluid that she had, but no, ended up being she had clots in her lungs because of the cancer. Um, Other things that increase your risk of having clots is the fact that when we have cancer, most of you would have had a port, for example, or they have intravenous lines, those can get clotted as well. The fact that we're immobile, mostly we're in bed sometimes when we feel so bad, that tends to promote the formation of clots in our legs, for example. So it's another issue that we treat that we have to be super careful with. And this is what I just told you about the 20% of cancer patients develop that clotting in the legs at some point, and 20% of all the clotting in the legs occur in cancer patients. Um, Lastly, I want to talk a little bit of arrhythmias. One of the things that we get a lot is atrial fibrillation. That's in an irregular rhythm of your heart. It's important to recognize that because patients who have this are at particular risk for having strokes. So it happens a lot in cardio oncology. We see it every day. And it's difficult to decide how to treat these patients because these patients are going to have multiple medications that can interfere with the treatment of the prevention of the clot forming in the heart that can give you a stroke. There can be interactions between medications. These patients may be bleeding because they have a cancer in the colon or in the bladder, for example. So giving them a blood thinner to prevent strokes may not be the best strategy in the world. These patients may have metastasis in the brain, giving a medication that uh, thins the blood may lead to the tumor in the brain bleeding, for example, which makes the situation immensely worse. They can have fluid in the lungs. We can make that bloody if we give these medications. So it gets really complicated. And it's part, again, of the things that we do to address different issues as we see these patients. Um, there's a particular arrhythmia, a particular medication called ibrutinib. I don't know if anybody in the audience has a condition called CLL or chronic lymphocytic leukemia. We use this medication a lot for this particular condition. This particular TKI is one of those medications uh, makes the risk of atrial fibrillation increase dramatically. So we watch these patients particularly carefully. Now, just a few words to finish. So, cardio oncology in 2024, how we make an impact? Sure. I strongly believe that the advances in cardiovascular pathophysiology, meaning the things that we see causing heart disease and the imaging that we have pioneered in our subspecialty, have made an impact in patients' life. For example, we did not know these patients that received the immune therapy had the potential to have not only that inflammation of the heart, but they can have acceleration of blockages in the areas of the heart because we rev up that immune system. So now we recognize that. There are therapies, there are specific therapy called CAR T cell therapy. I'm not going to go into that, but that can produce a particularly, again, immunological reaction in the body that we have come to recognize that can affect the heart. There's a condition called amyloidosis, which we thought was very rare, but now we think it's very common and it can affect the heart. So it's another thing that we have been able to recognize. And GLS and POCUS relates to different technologies that we have developed to recognize cardiac complications in patients with cancer. Now, what are our immediate goals in the future? You know, we cannot include every patient who has cancer in for a clinical study. As I mentioned before, it's a minority of patients that will have cardiac complications because of this chemotherapy or radiation therapy. So we have to be able to decide which patients are at the most risk so we can surveil them, we can follow them through time, and we can implement different therapies in a particularly enriched group of patients. We cannot treat everybody because we're not going to be able to tell a difference whether the therapy worked or not if the number of patients affected is too small. We also have to find out if there is any risk factors beyond the risk factors that I told you. If you have high blood pressure, diabetes, a history of cigarette smoking, a family history for early coronary disease, um, or high cholesterol, I know that I have to watch you, particularly if you've had heart disease before, but maybe there are risk factors that we have not recognized yet that put you at risk. So we're trying to identify those. And the other thing is that we have to improve patients' compliance. And this is a message that I have for you guys. And it is that once you receive a diagnosis of cancer, that's so disconcerting, right? All your focus is, I have to fight this, I have to survive. But the truth of the matter is that there's other things happening in your body, whether it's blood pressure, whether it's hardening of the arteries. We have to be able to chew gum and walk at the same. We should be able to take care of those things as well. Now, most of the cardio-oncology, most of the stuff that we do is not taking care of the complications of cancer. It's taking care of things like hardening of the arteries, that's called coronary artery disease. Many times a surgeon will tell us, listen, this patient has a lung tumor, I have to take it out. Can the patient go for that safely? That's called a pre-op evaluation, so we do that a lot. We see tons of patients with either high or low blood pressure, and we address those. We see patients with high cholesterol. We see patients with that arrhythmia that we mentioned before, the atrial fibrillation. A lot of these patients will faint for different reasons. Maybe you're too dehydrated, maybe you're too stressed. Pain can make you faint. There's different explanations. So we do a lot of that as well. Um, Very importantly is to recognize that oncology, unfortunately, like the rest of America, many times is not a level playing field. There are racial and socioeconomic factors that are very important. For example, after receiving Herceptin, that medication that I told you for breast cancer, uh, African Americans have 3 times the rate of heart failure as Caucasians. Do we know why? Not entirely sure. Maybe blacks have more hypertension, they're more at risk. Maybe it's a genetic issue. It's something that we have to decide. Um, if we have any evidence of decrease in heart function when we give this medication trastuzumab, the number of patients who have heart failure is double also in blacks. Um, Hypertension, diabetes, and obesity and low socioeconomic status is much more prevalent in African Americans, as I mentioned. So we cannot be blind to this in a society. We have to be able to address this and make it a level playing field in which everybody has the same opportunity. And it is something that goes beyond cardio-oncology. It's more of a societal issue, I believe. To be honest, in the last 40 years, US life expectancy is lagging behind most of other advanced nations, probably because of this. Um, I'm not sure that I want to make any comments about this, but there is a strong association between political lean of a given state and life expectancy. I have no idea what to make of that, but somebody showed me a slide saying that, so I will leave it as food for thought. Unfortunately, because of political considerations, expansion of different tools such as Medicaid, in which we can provide healthcare to a lot of these people in lower social economic status, is not being done in every state, even though the United States promises to pay for, I believe, 95 or 98% of the cost. And to me, that is a shame. I'm not saying this with any kind of political lean, believe me. I'm saying this as a physician. I think that we should try to give everybody the opportunity to have the best healthcare that they can receive. Now, um, what are objectives in the future? We want to decrease the downstream chance of complications across all the risk continuum in these patients. The problem that we have is just like heart disease, cancer rates are increasing, and the age and the risk level in which the patients are getting the cancer is increasing as well. So it makes life very complicated for us. Fortunately, we have better tools to image these patients and diagnose their cardiac conditions. And I mentioned things in here. There's something called 3D and now 4D echocardiography, ultrasound, that allows to have much better imaging of the heart, much better MRI techniques, PET scanning, CAT scanning, et cetera, et cetera. For the first time last year, the European Society of Cardiology, or ESC, now established some guidelines to help us treat these patients with different conditions. They're not perfect because we still don't have enough trials, enough tools to let us know how to treat them properly. But in the next 10, 20 years, this specialty will explode. As I mentioned before, we are getting older. We're having heart disease at an older age. We're having cancer at an older age. The number of patients will increase dramatically. We'll have trials that are much easier to populate, and we'll have better answers. Um, I just want to say by saying that patient involvement is key. I would love for you to seek, if you have risk factors, the help of a cardiologist to define the fact that you are at risk for complications like heart attacks in the future, or strokes, etc., etc. If some of you are involved in trials, I congratulate you. It's the only way we have to advance medicine. We cannot just give somebody a medication and say it's going to work. We have to give the medication to a group and then a dummy pill to the group and see if it truly works. That's the only way to find out. So if you are involved in trials or considering getting involved in trials, I would love you to do that, and that will be key for us. What are the things we need to do? Again, disease-specific protocols. If you have breast cancer, this is what we want to do in terms of preventing cardiac toxicity. If you have pancreatic cancer, this is what we need to do, etc., etc. We do have now some protocols for medications such as the anthracyclines, as the Red Devil, the TKIs, the immune stuff. If you get inflammation of the heart, monitoring certain parameters in the electrocardiogram, or if you have high blood pressure, how to prevent you from having clots in the legs. We now have stuff for that. And finally, survivorship. We need to follow survivors of cancer that are asymptomatic from adult cancer, because as I told you, many times these patients will end up dying of heart disease, or have heart complications more than cancer complications as they get older. Um, so again, we'll identify appropriate patients for surveillance, find actionable risk factors, improve both physician and patient compliance with surveillance and treatment. We don't have, sometimes we over test, so we need to make sure we don't do that. We want to include patients in registries and follow them through time, and make sure that we don't have unknown side effects of medications that we didn't identify at the very beginning. Imaging is key. We can only identify what we see, so we're having better techniques all the time. And finally, we need data. We need to know what is it that we're treating. We need to know that the treatment that we're doing is effective. And again, the future is very bright for us. We have the tools now. Now we have a whole community that is dedicated to this. When I started this, it was just a few of us. Now is thousands. I belong to a thing called the Cardio Oncology Worldwide Chat. It's literally cardiologists from the entire world discussing things in WhatsApp. I presented a case to the global community yesterday, and they helped me a lot as to what to do. It was a very unusual case. We see very unusual stuff all the time. So you cannot pretend you know everything. And if you consult other people, all of a sudden you don't only have a second opinion, you have a third, fourth, a 500th opinion, because there are so many cardiologists in this chat.